Thank you, Dr. Manticonti, for that lovely introduction and the word exciting. I am not sure if our presentation will be exciting, but we hope that you will have an understanding of how some of the newer CMDs as well as older CMDs want to interact with our providers and how we are now instructed to develop policies. So thank you for inviting us to be your speakers today. We thank all providers from ACIP for your services and expertise that you provide to our Medicare and Medicaid beneficiaries with both acute and chronic pain syndromes. I am Dr. Leslie Stevens. I'm actually not a chief medical officer like my colleague. I'm a contractor medical director for Novitas Solutions, also representing our sister company, First Coast Service Options. Presenting with me is Dr. Meredith Loveless. She is a chief medical officer for the CGS administrators. She's an expert in policy writing and our lead CMD for our national work groups when developing policy for procedural interventions for pain management. Okay, on our next slide, just very briefly, we're going to go over the agenda. I hope our presentation, at least my part of the presentation, will not be too simplistic after getting to hear a little bit of the lively discussion with the Honorable Senator Bill Cassidy. But I did want to go back over, I found that in my short career with Medicare, how many physicians might not know and understand the rules of the game, if you will. And this is from our perspective as MAC contractors. So we're going to do Medicare coverage overview, define about what a Medicare administrator contractor does, local coverage determinations. We're going to touch on the comprehensive error rate testing and the important 21st Century Cures Act and LCD development. And finally, we'll do the facet joint policy, which is the majority of the slide that will take you through how this policy was developed within these frameworks. Okay. Now, Medicare is health insurance by law. You just got finished speaking with the Honorable Senator and understand that. Many providers, when we're working with them, I think maybe forget this, believe it or not. So the Social Security Act was legislated in 1965, and it governs everything. Who is eligible to become entitled to benefits, what constitutes Medicare benefits and exclusion, payment mechanisms and methodology, provisions on cost sharing, who can become qualify as a provider or a supplier, and appeal rights. And the next slide is just really to reinforce this hierarchy. So Congress, through the Benefits and Coverage Statute by the Social Security Act, 1861, the Benefits Section, 1862, and the Exclusion Section, the Benefits Section is 1861, 1862 is the Exclusion Section, and 1848 the Payment Section. Any changes to the Social Security Act require an act of Congress. CMS is the interpreter and operationalizer of the law through regulations. I think you all probably know about our internet-only manuals, the extensive amount of material in those. And contractors, which include the MAC, which we're representing, AB MACs, Medicare Administrative Contractors, and other contractors, for example, recovery auditors, qualified independent contractors, and supplemental medical review contractors, just to name a few, are used by CMS to review and adjudicate claims for LCD development and for program safeguards and ultimately customer service, because just like you, we are interested in providing excellent care through you to our beneficiaries. Okay, this is a brief slide on local coverage decisions, and they are basically local Medicare coverage decisions created by Medicare contractors in the absence of a specific statute, regulation, or national coverage. Sometimes CMS does ask us to write a policy as an adjunct to national coverage. The LCD will define the service as covered and under what specific clinical circumstances a service is reasonable and necessary. Historically, it is a much quicker process than NCDs. I think with the onset of 21st Century Cures, that's been extended slightly. And services, again, must be reasonable and necessary, even in the absence of an NCD or LCD for Medicare coverage. And that's really our Bible, the Social Security Act, Section 1862 A1A. Just for you to know, there are 7 AB Medicare Administrator Contractors for jurisdictions throughout the country. And on our Pain Management Intervention Work Group, our national work group, there are representatives from all 7 on that work group. Because the RNN is the backbone, which RNN, reasonable and necessary, is the backbone of the Medicare healthcare by law, it certainly deserves its own slide. So I'd like to take a look at the next slide, which is what is medically reasonable and necessary? When you, in the earlier presentation, Dr. Manchakanti talked about simply documenting what you do. If we could get physicians to get back to that, I think I think we understand from a doctor standpoint implicitly what is medically reasonable and necessary. We know how to document what we're doing for our patients, and we have the integrity and the ethics to be able to document that. But sometimes with all of the regulations, it gets obscured. So the Section 1862A1A directs the following: that no payment may be made under Part A or Part B for any expenses incurred for items or services not reasonable necessary for the diagnosis or treatment of illness or injury, or to improve the functioning of a malformed body member. And this as a Medicare Administrator Contractor, we would have to determine if an item or service is reasonable and necessary under this act, and if it is safe and effective. So that's very important. Not experimental or investigational, and appropriate, including the duration and frequency in terms of whether the service or item is furnished in accordance with accepted standards of medical practice, furnished in a setting appropriate to the beneficiary's medical needs and condition, ordered and furnished by qualified personnel, and one that meets but does not exceed the beneficiary's medical need. So, for any service reported to Medicare, it is expected that the medical documentation clearly documents that service meets all of the above criteria. Now, certainly before and ongoing, why do we develop LCD? LCD development processes can include, from CMS directives, a validated widespread problem. So these are from other functional contractors, medical review, cert findings, data that we would be running within our own MAC jurisdiction. If it's a significant risk to the Medicare Trust Fund, high dollar and or high volume services. If it's a matter of assuring beneficiary access to care, that's very important to us. If we're seeing frequent denials issued or anticipated. And before, when they were developing the 7 MAC jurisdictions, certainly multi-state contractors were trying to create uniform LCDs across each jurisdiction. Now the directive is across the country, and Facet Joint Policy for you all represents this national effort to come out with the same policy so that the same coverage for our beneficiaries will be in any state they choose to receive it in. Okay, I'm going to step sort of aside to just go over quickly the Comprehensive Error Rate Testing Program, or the CERT program. Medicare fee-for-service improper payment rate was first measured in 1996. The Department of Health and Human Services Office of the Inspector General was responsible for estimating the nation's Medicare fee-for-service improper payment rate from 1996 to 2002. At that point, the OIG recommended to increase the sample size for a more validated measurement. And currently, CMS has implemented a CERT program with separate CERT contractors to carry forward the CERT program. This includes an independent review of approximately 50,000 claims of Part AB MACs and DME MACs during each reporting period. The CERT program, this number, it's a statistically valid random sample with results considered to reflect all claims processed by MAC during a report period. The CERT contractor uses a complex medical review, NCDs, the National Coverage Determination, CMS coding policies, and each contractor's LCDs and articles. And we are given guidance on what to do if a Medicare Administrative Contractor has issued an overpayment or an underpayment on the claims with errors determined by the cert contractor. This annual error rate results is really a report card of the Medicare Administrator Contract in Human and Health and Human Services Agency financial report. Now, I really want to make this clear when we bring up this cert error rate. It's not a fraud rate, but it is a measure of payments that did not meet Medicare requirements. And most of those requirements revolve around documentation. What I'd like to show is something that Dr. Manchikanti was on your homepage in ACIP. And by the way, that is a excellent homepage. I was just really impressed by the content of it and what you all could link to and find in terms of trying to keep up with a very complex healthcare system called Medicare. So thank you for that. Facet joint procedures and interventions, what is the problem? Well, the OIG did separate investigations that have been conducted in the past and present for interventional procedures for pain management. In 2006, they looked and found that 47% of Medicare payments to physicians for facet joint injections nationwide did not meet Medicare requirements. In 2016 to 2018, they specifically reviewed Noridian, jurisdiction E, and that audit found that Noridian did not pay physicians in accordance with Medicare requirements, and also found that that there was going to be money that was due back to the program because of lack of proper documentation. Most of that was the case. What the OIG then recommended to Noridian, and again, this was just one of the jurisdictions, but this is a nationwide problem, was that we were to provide annual training to physicians and their billing staff for facet joint procedures. Our update today, although it's not going to go into all that detail, is given in the spirit of collaboration with you, our valuable providers. Okay, and one last slide before turning it over to Dr. Loveless, and that is the 21st Century Cures Act of 2016. There are many components within this act, which is also known by other short titles, including Helping Family and Mental Health Crisis, Reform Act of 2016, Increasing Choice Access and Quality in Healthcare for Americans Act. It specifically, if you look at the bottom part of that, revised the Program Integrity Manual, Chapter 13, which applies to local coverage determinations. And the goal of the update was to provide greater transparency, consistency, and patient engagement, as well as increased engagement with stakeholders such as yourself. So that is the backdrop for the 21st Century Cures. And with that, I will now turn it over to Dr. Meredith Loveless.
Thank you. And thank you everyone for having us today and for the invitation to be here with you. Dr. Stevens and I hope that today's presentation will help you to best understand how you can, as individual providers and as an organization, engage in the policy development process as you did with facet and throughout future policies. And so we're that input and engagement from you is essential for our work. And I appreciate Dr. Stevens providing the background for you to understand that when we are doing our work, we are following the rules and regulations that are defined for us in terms of policy development by law. So we have to follow each of the steps as mandated, and we aren't given a leeway to change that process. So I want to share the process that we work within and how you can engage throughout the entire process. So 21st Century changed the development of local coverage determinations by each of the individual MACs by mandating a combination of not only the individual MACs medical directors or policymakers interpretation, but a demand of clear interpretation of medical evidence, as well as input from physician experts and societies. And that's the premise of Medicare policy in 21st Century. And so to best understand, I'm going to go through the steps of that process. I'll call the life cycle of an LCD, and then later I'll be specifically helping to understand how you can engage in these steps. So how do we determine if we need an LCD? How do we decide what we're going to focus our energy on? So a lot of times that's initiated by an LCD request or reconsideration that comes in from providers or organizations. It might be something that CMS or the OIG has recommended as a topic of importance. Everything we do is going to be driven by data. As Dr. Stevens mentioned, we are going to look at dollars, volumes, because this process is complicated and time consuming. So we want to focus in on areas that are going to have an impact, hopefully improving quality of care, saving the trust fund, and answering the needs of that request. So everything is data driven. And then there can be additional other factors that might lead to an LCD development. The second step is going to be evidence review and analysis. So when we are looking at a topic, we have to ask, what do we know about it? Is there evidence or not to support this? We would often develop a PICO question, so looking at population, intervention, comparators, and outcomes to best understand what do we already know, what do we not know. An extensive literature search is conducted, and then analysis of the evidence. We look for risk of bias and other factors in the evidence that need to be considered, often looking towards systems such as GRADE or other rating of evidence systems, and then societal input. So all of those factors are considered in the evidence review. And then we look towards stakeholders and providers to better understand some of the clinical aspects that we may not understand if it's not within our specialty. When we started the pain management work group, which is a collaboration among all 7 MACs, the purpose of this work group was to be able to provide more consistency among the MACs throughout this process. And I think one of the big benefits of the group is that we're able to pool all of the resources among the medical directors. So we have a lot of different backgrounds. We have pain management, anesthesia, internal medicine, ER, hospice, and rheumatology, all different medical backgrounds. We have different expertise from, experts that focus on interpretation and grading of literature. Some of our members have a lot of experience in Medicare that they bring to the process, and some of us are less experienced but bring in other skill sets. So we're able to kind of tap on all of these different factors that can help us in putting together the best quality product. So moving on with the life cycle, we then have to, once we develop a draft LCD, if we will take that stakeholder and provider input often obtained through a contractor advisory committee meeting, and then we'll pull all of those resources together into a draft, and that draft is then presented at open meeting. So Dr. Manikanti mentioned the epidural policy. That's where the epidural policy is now. We have a draft that is being presented across the jurisdictions at open meetings. And so as I go through the presentation, you can better understand where you can play a role as that particular policy moves through the process. Once it's been presented, actually even once it's been announced, really, the comment period is open. So the comment period is something we take very seriously. That's an opportunity to find out, is there something that we're not getting right in our interpretation of the evidence or from the input that we've received so far that we need to consider in this policy? And so we take every single one of those comments are responded to, considered, discussed among the group. We look for additional supporting evidence if needed. How long that takes depends on how many comments we receive and what the workload that's involved in thoroughly going through that process is. So those comments are taken seriously, and then they're actually published in an article called the Response to Comment article, where our response to each and every one of those comments, we will combine them if they're the same comment over and over, but they're all acknowledged and responded to. And we consider those comments in the development of the final draft of the LCD, so that we have thoroughly engaged the entire process. And so that is how an LCD is developed. So I'm just going to focus in on a few more aspects, detailed aspects of this process. So one of the aspects that I think is particularly important is the National Contractor Advisory Meeting. So, prior to 21st century, a lot of times contract advisory committee meetings, and this is before my time, but from what I've been told, was mostly done locally. And I think that local input is very important. But when we're dealing with a policy that we are hoping to implement nationally, we are seeking out national experts. And so we are going to look towards the trying to find experts. And so, for instance, in the facet policy, we found these experts in multiple ways. We actually asked some of the pain management societies who would they nominate, who would represent them. We asked our local CAC members in each jurisdiction, on this topic, who do you recommend as experts? So we were making sure we engaged our local CAC members and that they're still valuable and contributing to the process and helping us identify the experts. We looked towards those who were authoring guidelines, those who had a strong presence in the publications or the manuscripts on the topic. And so all of these factors helped us to create our national expert panel. In that panel, we also looked to have geographical representation to make sure that we were represented across the country, a variety of academic and clinical practices. We also look towards various specialties that perform or are involved in the procedure. And while I understand some specialties have more direct expertise in intervention, we also want to know for the doctors who are providing the referrals, who are following up with the patients, and other aspects of that intervention, the surgeons who may or may not be involved, because they all have different expertise and input that could impact the policy, and that the policy could then turn around and impact them as well. And then finally, we are looking for an evidence-based review. And this is very important because because when we're talking to this panel, there's a tremendous amount of experience and stories. And I think I actually love hearing those, except for that we can't use them. And so we have a limited amount of time in our meeting. So we've got to focus on the evidence. That's the only part that we're allowed to use in the policy development. So we've got to focus in, get the most information we can about that evidence from our panel during that limited time that we have our national advisory meeting. And so when we did the facet policy, we tried to identify every society that could be involved, and this lists all of the different pain societies that we contacted and that we communicated with throughout the process. And so again, I think you can see that we're making a strong effort to involve the stakeholders in this process and gather as much input as we can. Then before we can have an advisory meeting, we've got to have questions. And so before we get to the point of having this meeting, we're going to have had an extensive literature search. Fortunately, we have some excellent resources. Some of the MACs now have policy analysts, librarians, a whole bunch of different resources. And when we work together as a collaboration, that's a bonus, because then we can tap into each MAC's resources and kind of optimize our ability to utilize them. Literature searches are extensive, include PubMed, Cochrane Review, EBSCO. But then we also went to the pain societies and we said, you're the experts. You know this topic better than we do. What are the key articles? What are the issues? What are the articles we can't miss when we're reviewing this topic? And you all provided that for us. You gave us a list of literature, key articles, helped provide some of that literature. So it made a big difference to make sure we were reviewing those articles. And then we really focused in facet and understanding that in the past, one of the big problems with this particular topic was a lack of clarity and definitions. And I know Dr. Manikani and I had several email communications on that challenge throughout the process, and that we really needed to create clear definitions and they needed to be consistent across the country, because that was causing a lot of confusion. And that confusion was also partly responsible for why, when Dr. Stevens reviewed that OIG report and some of the challenges that were happening, some of that stemmed from lack of clarity and a lack of understanding of the definitions and what the expectations for reasonable and necessary were. So we really tried to clarify those definitions. We asked our panelists to agree on those definitions to help us make sure that we were providing the most clarity we can, which is hard because it is not a clear topic per se. Then we went through the literature and we reviewed the literature and we tried to identify what are the controversial points here. What do we know from the literature is fact, and then what are areas maybe gray zone or controversial? And we tried to focus our panel on these controversial topics, because if we already knew the answer, we didn't need to spend our time on that. So our panel had a big challenge, because we were hitting them with the stuff that wasn't clear and that we needed their expertise and input to help us clarify that. And if you had listened into our panel or went back and reviewed the transcripts, which, by the way, for every one of these national meetings, they're recorded, they're transcribed, and they're available on the MAC's website. So you can always go back and hear hear this process yourself. They didn't even, even our experts sometimes didn't agree on some aspects of these topics. And so I think that demonstrates some of the challenge that we do have in the process development. And then we tried to make sure that everyone knew what we were doing. So all of those societies that I listed, we sent them a letter and said, we're having this meeting. Please notify your membership, ask them to participate, listen in. We understand that we couldn't take every single society's recommendations for membership, but get on, listen. You're going to have a time for comments, so please get involved. We notified all of our local CAC members. We posted it on our websites in an effort to make sure that everyone had an opportunity who was interested to participate. And finally, as I said, this was all posted publicly once the meeting was over onto each MAC's website. The next step after our meeting was to develop the actual policy. So through our expert, we learned about additional literature, more work to do in terms of gathering information and tackling some of the difficult questions that arised. So we continued with our evidence review, and then we combined it all. We took the evidence review, we took the CAC input, we took the definitions, we took the experience from Medicare from the past in this policy, including OIG and CMS input. We communicated throughout the entire process with CMS on multiple different levels. And then we determined a coverage criteria and presented that to all of you at our open meetings across the country. And I just want to jump quickly to the evidence review process, because I think it is important before, when I say evidence review, exactly what I'm referring to. And so we're looking at the quality of evidence, and I know many of you that are in the audience today are experts on this, but for those that this isn't your background, we're looking at that hierarchy of evidence, starting with the lowest quality evidence being case reports, case series, case controlled studies, moving upward to cohort studies, and then finally the gold standard of randomized controlled trials. And then looking at meta-analysis and systematic review. So we're not going to look at a review article where key articles could have been admitted based on the author's experience or biases, but a systematic approach, and then looking for disclosure of underlying bias in the actual investigation. And then to take it a step further, we also are going to take the systematic review and meta-analysis, which I think is really a looking at the quality of evidence under a lens. And, that's going to be limited by the quality of what's going into those reports. So were the randomized controlled trials or were the cohort studies that were used, were they of high quality? Because that was going to impact what the results or the accuracy of a systematic review or meta-analysis is going to tell us. So this process is conducted by the medical directors, but also we have the policy analyst and additional teams of experts with this type of background to help us break this down and really understand what we're reading and what we're looking at. And so then we, to take it to the facet policy, so we took the policy to open meeting, got your input, and then utilized that input to develop a final policy. How we came to our conclusions is described in the rationale portion of the policy, but very important is that response to comment article, where we break down each of those comments and provide the answers to why did we decide what we did. And so I'm going to provide a few examples from the facet policy just to give you a little understanding of what we were thinking. And I'm going to give you some straightforward and less straightforward, a couple of examples just to understand what thought process we're going through or the whole process we're going through. So one example was a requirement for imaging. So this was a straightforward example. This one wasn't difficult. The policy states that facet joint interventions done without CT or fluoroscopic guidance are not considered reasonable and necessary, and that we expect these procedures to be performed with CT or fluoroscopic guidance. If they're done with ultrasound or MRI, that is not going to be coverable. Why? Because that's what you all told us. I mean, it's in the literature, it's supported by evidence. Your society said this is how it should be done. And the panel of our experts all agreed. I loved this because everybody agreed that's optimal. And that's where we have the quality of evidence that we're not dealing with controversy. This was also supported by U.S. Department of Health and Human Services. It was a recommendation from the OIG report, from the consensus guidelines that were written in 2020, from NOS guidelines, from your guidelines, from your societal guidelines. And so this is clearly standard of care. So that went into the policy. So an easy example. Now an example that I think this is an important example in that here is an example where we're relying on, we don't have evidence. So the topic of interest is, do we require a trial of conservative management? That was in all of our previous policies, and it's in all of the commercial policies. So should we require a minimum amount of time that a patient experiences pain with documented failure of conservative treatment before proceeding with intervention? And very few studies had a conservative arm. It was in the AHR report, but there wasn't strong evidence. So we had to look towards our experts. Is this standard of care? Is this what we do? What we found was that the majority of our CAC panelists agreed that the conservative management trial was recommended because a lot of patients do get better during that time period, and maybe they don't need the aggressive intervention, but our societal support was also strong for conservative management. So again, this is demonstrating where we are listening to you and asking for your input in areas that we can't just turn to the evidence and answer. And then we get into the areas that are definitely more challenging. And this is where there's controversy and the evidence is not clear. So an example that I'm going to use for this is the number of diagnostic blocks required and the % pain relief required. And I thought this was well summed up in the consensus guidelines from 2020, where it stated the cutoff designation of a medial branch block as positive is one of the most controversial areas in pain medicine. So the evidence was conflicting. There was evidence to support it. There was evidence against it. And the panelists didn't agree during the CAC meeting, and both had evidence to support their opinion and valid arguments in their discussion. There was differences amongst the consensus guidelines. And so as medical directors, we are faced with, well, how are we going to reconcile this? What do we do in the policy? Because we need to be clear, we need to be specific, and we need to reach the goals of we need to define reasonable and necessary. This was voted on by our panelists, and we had a score of 3.2 out of 5 favoring the dual block regimen. So it trended towards the dual block, but again, it was kind of right, and it was more towards the middle, so not clear. And in the final policy, what we ended up doing was that we did choose the diagnostic block of 80% primary pain relief. Why? Because most published literature utilized the 80% cutoff. And there is an uncertainty in the evidence in that 50 to 80% cutoff group. So the studies were consistent, showing the benefit, or that dual blocks with 80% cutoff were more likely to have a positive response to the radiofrequency ablation. This decision aligned with some of the guidance. It aligned with the ASIPP guidance as well as the SIS. And while our panelists were split, it did favor dual block. And we felt that it was clinically important to get the correct diagnosis in order to achieve the best outcomes from the treatment. And so in the end, we felt that the evidence available supported that the diagnostic accuracy of the dual block and the 80% cutoff predicted the greatest improvement in treatment. And we had to balance this. While we understand that this excluded some patients for treatment who may potentially benefit, given the lack of supporting literature to define the population and the current evidence best supporting the 80% group, that this was best supported by the dual block cutoff. So that's the rationale and how that decision ultimately was made. And so I'm jumping back to what Dr. Stevens introduced in is the definition of reasonable and necessary, because that's really the backbone of everything we're doing. Our job as medical director and policy writers is to define this and create policy that reflects that determination. So we're asking, is the service reasonable and necessary? Has the proper diagnosis been made? And is the treatment supported by the evidence and shown to be effective? Was it acceptable and consistent with standard of care? What's the risk and benefits, the alternatives? And is this experimental or investigational, which would then be answered by the evidence? And has this been looked at in the Medicare population? Because we have a fragile, higher risk population, multiple comorbidities. What do we know about this treatment in the population that is the large majority of the patients that we're serving? I do want to bring to note that cost and utilization are not in this list. And that's because they're not in the definition of reasonable and necessary. So I'm not going to say that cost isn't important. I think that your previous presentation really emphasizes the aspects of cost, but we are not allowed to consider that in our determinations, that these are the questions that we are by law focusing on and utilizing in the decision making. So again, it needs to be safe, effective, not experimental, and we need to provide clear definition and understanding of appropriate use, duration and frequency in terms of where the service or the item is used. And so those pieces of the policy are required by us to be able to put in there. So, some might say, well, why do you even have to define that? This is why. That's a requirement that we have evidence and we make the best evidence-based decision of why these pieces in the policy. Who can do it? Where can you do it? What can you do? When do you do it? What's the right patient for the right procedure at the right time? And we say that a lot in Medicare. And then finally, a new policy rolls out. And what does that look like? So when the policy rolls out, we're going to publish that response to comment article as well as the billing and coding article. And then one of the things that we're really trying to work on is education. Because if people don't understand the policy or they have questions that we haven't answered, then this policy isn't going to be successful. And not just only for us, but for the patients and for you as providers to make sure you're getting appropriate reimbursement, that you know what you're supposed to do. So in the Facet joint policy, when we rolled this out, we asked you to help us. We notified all of our pain management societies. We have this new, the Facet policy is now going live. Please help inform your membership. Here's a list of, here's the response to comment articles. Here's frequently asked questions. I know Dr. Stevens and I provided webinars and presentations for our jurisdiction as an opportunity to ask questions and answer questions. And the first presentation in our jurisdiction, CGS, was so well attended And they had so many excellent questions that we did it again to be able to go back and look at those questions and make sure we are providing answers. And I think that, you know, in my couple of years with Medicare, I found that really helped to prevent some of the confusion and questions that usually come in when a new policy rolls out. And as societies, you played a key role in helping roll that out and helping people understand what we're doing. And then what happens if you feel that something in this policy is no longer accurate or it needs to change? And so that's where an LCD reconsideration can come in. So in order for an LCD reconsideration to be valid, it has to have evidence to support the reconsideration. The reconsideration has to have a clear request for change. So you send in, this is part of the policy that we feel needs to be changed. This is what we would recommend it be changed to, and here's the evidence to support it. It does require that evidence be peer reviewed and published. We can't accept unpublished evidence. And so that would be the process. If and there I expect things would be changed in the future. There may be additional research that answers that gray zone of that 50 to 80% group on dual diagnosis. So many factors that additional evidence and learning may result in change in the policy. And so in summary, I want to just to go over with you as providers, what are the top 10 ways that you can engage in the policy development process? So one is most of our LCD and request and reconsideration come from industry, asking for coverage for different devices and things that are hitting the market. My favorite requests are the ones that come from providers, because you're the ones taking care of the patients. So I think that those are the most valuable to understand. This is something that we think needs to be addressed by policy. Research. A lot of you in the audience are researchers. By producing high quality literature and tackling the answers to these questions in an evidence-based way is extremely effective and important, and we are held to that standard by 21st century. So we need evidence if we're going to make change. Share the literature with us. If a new paper's been published, if you think it's pertinent, even if it's not ready to lead to a policy change, I welcome that education, and I think the rest of us do. So again, that engages us in the process. Serving as an expert, a CAC member as a subject matter expert, and several, I know Dr. Mandaconti has served, and several of you in the audience has served, and that's, I wish we could give you compensation. It's a lot of time, it's a lot of energy, it's not necessarily a fun process, but it is critical to this process. This is our biggest opportunity to get input from you as providers. And again, if you do serve as an expert, we do ask, focus on that evidence, bring that evidence to us. By participating in your society. So all of you convening in New Orleans, and I hope you're having a great time and getting to collaborate and finally see each other face to face. But by joining forces and preparing guidelines and providing, a lot of societies will put together a letter of recommendations, and those are all valuable and important input. So being active in your society, as a society providing input, it's going to be a whole lot easier for us to read a letter written by a society of recommendations than 50 individual doctors, simply because if we have to go through 50 letters, that's going to make this take that much longer. And I think most people want to get this done at some point. So so that it facilitates and speeds up an already slow process. Utilizing evidence-based, using systems to systematically grade the evidence is very helpful. When societies get together and produce evidence-based guidelines, especially using a grading system, that is going to help us, because then we know how you're thinking in terms of guideline development and what evidence you're using, and you're providing us with something we can pull into the policy and use. So using that grade, that or the U.S. Preventive Task Force, one of the grading systems, is extremely helpful. And then at open meetings, this is your opportunity to share your input on the policy at your local MAC level. as well as submitting comments if there's concerns or changes you don't think has been addressed. Again, backing that up with evidence, because evidence is the only language we're allowed to talk in, and when we're dealing with policy development. And we consider all of these sources important and impactful in the development of the policy. And then finally, make sure that you have full disclosure on potential for bias. I know that some people have industry sponsored. If we didn't have industry sponsored, we wouldn't get new technologies. We wouldn't be able to gain some of the advances we make, but we need to know about it so that we're fully transparent in our process. We want to, I want for you to be gracious with us in terms of understanding we're fulfilling a requirement determined by law in the policy process. And there's aspects of that we're unable to change. And so I think that when we understand that and understand each other, we're talking the same language. It's not personal. We're doing our job, and you're doing your job, which is extremely important to us because you're taking care of the beneficiaries that we serve. And so ultimately, I think we're all, most of us are, all of us are working towards the same goal. And unfortunately, we have those few bad apples that kind of, that trigger a lot of the fraud and abuse that Medicare policy has to regulate. But for the most part, we're all on the same page, working together for the same goal. And then participating in education, helping us get the word out, helping to prevent claims from being denied that shouldn't be denied, and making sure that we get access to our beneficiaries for the best care that we can provide. So that being part of that education really facilitates this whole process for all of us. And so I hope that this shares with you some of the many opportunities there are for us to collaborate and work together for this policy process and for future policies, that we can continue that working relationship. And I very much appreciate every one of you who has been involved in the facet and the epidural policy and in any future work that we need to do. And so with that being said, I'm going to open the time for any additional questions.
Thank you. Am I on?
I can hear you.
I can hear you.
Thank you. Thank you for both of you. That was exciting, still exciting.
Okay.
It is not that we like everything, but still it is very good. And the policy, actually the Century 21, that 21 Act, that language was introduced by ASIP. And sometimes we feel sorry that why did we do that?
Be careful what you ask for, huh?
Hopefully it will be good eventually. That is what CMS told us when we went to them. I have comment. I know we are not talking about epidural policy, but when the epidural policy was released, none of the CAC members were aware of it. It took me 3 weeks to find out that it was released. And NGS already had their open CAC meetings, and none of the CAC members knew them. They were informed that just the day before. I know NGS is not here, but it was not, rollout was not very good at all for epidural. So we are hoping that probably the comment period may be extended.
Okay. Well, thanks for the feedback, and I'll send out a reminder to all of the different medical directors that are involved, just a reminder to make sure that they've got their announcements out.
We actually had our open meeting today, earlier, for the Novitas Solutions, and yesterday for First Coast Service Options. So, and we'll be collecting response to comments. I'm sorry, yeah, response to the policy.
Okay, thank you. And the main questions related to the facet joints are sedation, one side, more than 2 levels on single side, and multiple procedures in the same session. I know the answers for these. I communicated with Dr. Loveless, so I have the answers, but these are the questions. people are asking. If you want to comment on that, that would be good. And we can invite others to ask the questions. Please come to the microphone and be brief, respectful.
I'm hearing some chuckling in the background. I don't know about that, guys and gals.
So Dr. Loveless, in the letter you sent me that mild sedation was acceptable as long as patient does not lose the consciousness.
Yeah, so the goal would be that the patient would still be able to communicate if there was pain or something that was going on to be able to communicate, and that was consistent with published guidance and standards, and so so that mild sedation would be the acceptable route, putting the patient completely to sleep based on the current published literature and evidence is where the risk is increased.
The second question you answered for us again was in reference to the multiple procedures. The policy is very restrictive. As I explained in the letter, it is very expensive, and there are a lot of unintended consequences since Medicare Advantage plans, commercial insurers, Medicare, Medicaid, everybody is following them. So suddenly the number of visits are going to increase. 60% of our patients have more than one region involvement. So that is a major concern. And the answer from CGS was that under rare circumstances or some circumstances we can do it if we can document indications and medical necessity properly. Would you clarify that?
Yeah, so the objective there is that if you do have multiple procedures at the same time, one of the concerns that was brought to attention was that it can be very difficult to know, well, how do you assess that improvement in pain, right? So you have to have an improvement of at least 50% to continue procedures. So how are you going to assess that if there's multiple procedures done at the same time, knowing what procedure benefited what aspects, so that it becomes a gray zone when there's multiple procedures and there's a lack of evidence in terms of the safety and the long-term outcomes of multiple procedures. So that's one of the big challenges with multiple procedures. However, we did understand from the input that the CAC panel provided that there are times where that would be appropriate. So in those cases, it goes down to documentation. And actually, that's why the policy doesn't specifically state you can never do this, because that could have been something that went into the policy that actually is a little bit easier on our side, because then we can put in, a set standard that we're going to deny if there's multiple procedures. But understanding that wouldn't necessarily be the best thing for each patient, the policy says that we could reevaluate that on medical review. So if multiple procedures are necessary and that's what's best for your patient, then the ask is that that's documented, that there's a reason, and then that if that was to deny, which there's no, not saying that it would necessarily, but if it was, then we have that documentation requirement that we would need for the reviewers to understand why that meets that definition. Again, that reasonable and necessary that dictates everything we do. Why does it meet that? And as the provider, you are the best one to be able to provide that information.
So just for clarification, when we are asking about multiple procedures, we're not asking about in the same region. Like we do not want to do a lumbar facet injection with sacroiliac joint or lumbar epidural. We are asking about doing a lumbar facet joint procedure with a cervical epidural or cervical procedure with a lumbar epidural. So something like that, or both cervical epidural or lumbar epidural. So we are talking about two different regions, two separate anatomic regions. There is a lot of distance between them.
Yes.
So we really think that that is really going to create access issue as we move forward. It already has done in many of our patients. They can't afford the ride. It is difficult for them to come. They have to have 2 COVID tests, and people are going to forego their care. that is not what Medicare wants. Medicare wants everybody to have access, and that is one of the reasons we have the LCDs and this whole process.
Yeah,
So,
so in the national data, that was a minority, a small minority of procedures. However, again, that's exactly where that documentation comes in, why this is necessary. And again, that access to care can be one of the reasons. That might be the reason you as the provider feel that this is the best thing for the patient. So again, that goes back into that documentation, explaining that, and then putting in that this wouldn't compromise the ability to evaluate and assess the procedure, because their different regions would provide the information that those reviewers would need to be able to adjudicate and clarify that.
so if I understand correctly, so you are saying in minority procedures again, so we can't do it. Like I have 60% of my patients are involved with more than one region. So if I explain properly, document properly, can I perform 2 procedures in 2 separate regions in all the patients?
It would require that you had that you had a rationale that met reasonable and necessary for each of those individual patients. So I can't blanket say that would be acceptable, because this is based on medical review. And so if it was to deny and there was a medical review involved, that each of those individual patients would have to have a rationale for why they needed multiple regions. And so I can't say that they're a blanket, yes, all of them would be all of them would meet that coverage requirement, because it is based on each individual case.
Just as information for you, all Medicare Advantage plans have already decided that they will not approve no more than 1 region at a time. And Anthem, Blue Cross Blue Shield has done, Blue Cross Blue Shield has done. Several of the insurers are already doing that. Kentucky Medicaid has done that. So that is, it's all based on Medicare policy. So even though all these people are not covered by Medicare, but they are being affected. So this policy may affect beyond Medicare, the access issues. I don't want to belabor on that, but go ahead and John Prinskus is asking a question.
Thank you very much for your presentation. I'm Dr. Prinskus. I was a presidential appointee to Health and Human Services under the last administration. And I want to ask a question specifically about facets. Facet coding seems to be very dynamic over years. It was required for a while that you had to use contrast dye. Now, no contrast dye is required. What I specifically want to ask is the most recent change, where we are only reimbursed for 2 facets, as if anatomy stops after 2 levels, which has put many of my colleagues, as I talk to them, in the quandary of, do I just do those a 3rd level when it's clinically indicated and do it, quote, for free? And of course, as physicians, we want to do what's best for the patient. But some of my colleagues are saying, is this now opening the door so that Medicare is now going to say you can only do X number of a procedure and start whittling away, perhaps not at the compensation rates per CPT code, but now legislating to us that you can only do 3 or 2 or 1, and then we have to, quote unquote, for free, do the next level. So if you could provide clarity on what are we to do if a patient has 3-level facet disease and we are only advised to do 2 levels, are we just supposed to do it for free? Thank you.
And I don't think the intention of the policy was ever with an expectation that providers provide free services and utilize their time and expertise without appropriate compensation. Again, this was an area that it goes back to that documentation. If there was clinical indication of medical necessity for that 3rd level, then it needs to be documented of why that's the right thing for that patient, and then it may be reimbursable on medical review. the third level again was in the minority of national data. So looking nationally, most patients did not require a third level, and that was using national Medicare data. But for those who did fall into that, it wasn't meant to be restrictive or punitive in any way, but requires that documentation and rationale. So again, our recommendations are providers do what they think is the right thing for the patient, and then put in why this particular case stands out different from, the disease in this case extends to this level, and that without this, the patient would continue to have pain, which isn't the goal. So again, documentation, explanation of why, and do what you think is the right thing for the patient. And then my other thing that I want to make sure that everyone understands is that as things come up, that's what the LCD reconsideration process is open to reconsider things that you see as problematic or challenging. But again, we need the evidence to support it. So if evidence develops or there's evidence to support those things, then that can be submitted. But in these areas that there wasn't, in the process of development of the policy, these represented minority of cases at the national level. So that's not saying that, a certain practice may not see a higher percentage of patients based on different factors that may draw those select patients into a specialty site, but that on a national level, these were the standards of norm, and that can be considered on reconsideration with supporting evidence. So there is an avenue to address those.
We have Deborah Tracy, who served on both committees, epidural and facets, as subject matter expert. She's also a CAC member from Florida. She has a question.
Yes, I heard reverberate yesterday in our billing and coding sessions, and even in our J9 jurisdiction, that you acknowledge that there's a branch from above that contributes to the 4-5 level. So if we have facet disease at 4-5-5-1, in the past, you would expect a needle to be placed at 3-4 to get the branch above. But now I'm understanding, Dr. Stevens and I have had a few conversations about this, that if we put that needle above and only bill for the 2 levels, we would be undercoding, which would be an issue of fraud and abuse.
Dr. Tracy, yeah, maybe this would be better. We never want, first of all, proper coding is really providing the services, documenting what you're doing and billing appropriately. So we tread lightly on the terms fraud and abuse. We don't expect that from our providers. Yes, it happened. So I'm not sure, and maybe I need to speak with you personally about the anatomy better, because that's going to be a third level on the facet. Is that what you're trying to say to me, Dr.
Yes,
Tracy?
that if
Yeah,
we
that's
place
right.
the needle
Right.
above to
Right.
get the branch, that would be a third, for you, that would be a third level.
That would be a third, right.
Yeah. And
so
the way they're understanding it is they're going to be allowed to do that. And the way I'm understanding it is they're not going to be allowed to do that.
Yeah. It would be a third level, and I think your understanding is correct. It can be approved on appeal with medical review under those circumstances. And again, what Dr. Loveless was saying is we know there's going to be a lot of appeals. That is not why we wrote the policy. We're not trying to dictate how you all are supposed to practice. You're the experts. We looked at national data to see as a whole what the nation was doing. I know that, some states have proportionately more Medicare folks, and let's face it, older folks have multiple issues with their spine and osteoarthritis. But when we came up with this baseline policy, we are requiring at this point for any third level facet in a day, in a session, that would be will be denied, most likely be denied, and that if you document why you're doing it because of that additional nerve root going above, then it will be, if you've got the documentation there on medical review, it can be approved, but it does have to go to medical review.
So if they're only billing for 2,
Right.
but they're putting a needle in the above level that they're not
They-
billing for.
Yeah, they need to bill for all, correct coding is you bill for what you're doing, period. End of story. Now, whether you get paid or not, of course, it's another, coverage is not payment. So, but I think, I think you have to document what you're doing. That's what the AMA CPT coding guideline states, and that's part of the Medicare program and what dictates how we look at things. So yes, you would have to, if you're doing a 3rd level, you would have to document that and bill for it.
Thank you, Dr. Stevens. I think it is time, and we really, really appreciate you coming here, and we are developing these good relationships with Medicare directors. Dr. Berman was nice enough to speak at our billing coding meeting, and
Good.
really amazing. It is interesting to see how we interact and we understand. This is a very good educational opportunity, and we are very happy that we started that first at ASIP. Hopefully other organizations will do it too. Again, thank you, Dr. Loveless and Dr. Stevens. Wonderful.
Thank you. Thank you
Thank
very
you,
much.
and I hope you have a wonderful rest of your
Yes.
meeting, everyone.
And eat more beignets. Okay, thank you.